Now, these tumors, it's very weird, but they tend to attack women than men. There has been links between meningiomas and contraception.
So you
that
mean birth
rich
control,
in progesterone.
So birth control pills
Yes,
that
birth
are
control
rich in
pills that are rich in progesterone may make female, let's say, who have small meningiomas grow big. Or pregnancy, when you have a small meningioma, it tends to grow faster when you're pregnant.
This is the very, very best. I introduce the very, very next. Big deal. You know this is the big league. Unsanga mumihanda ya Kigali mega big fish. Word on the street turakaze. Habari gani mumeze mute. Yutse nshima imana kuva honda mukiye. If you want the long form, come close murabure. Wait, what?
The long form.
What did he say?
The long form.
What?
The long form.
the long form. The long form. Hello there. My guest this week on the Long Form podcast is Dr. Karekezi. A neurosurgeon by training, Dr. Karekezi remains one of the few Rwandan women in this profession. Operating in the Rwandan Military Hospital in Kanombe, she's one of the 7 Rwandan neurosurgeons currently serving patients in the country. In this week's conversation, we discuss her career choices, as well as the challenges she experiences practicing in Rwanda, the future of neurosurgery and brain health. I also discover what we need to do to avoid the #1 cause of brain trauma in Rwanda. Hey, before we get started, almost 70% of you who watch this podcast haven't subscribed yet. If you've been enjoying these conversations and want us to bring even bigger guests and tell even better stories, that simple click really helps us grow this community. It's free for you, but it means everything for us. So hit that subscribe button, join the community, and let's get into today's episode. Dr. Claire, welcome to the Long Form podcast.
Thank you so much for having me.
Not adding any of the foreign doctors who are in your field.
Yeah.
In Rwanda today, there are only 7 neurosurgeons. I think there's one of your colleagues who you told me is presently not in the country. So there's just 7 Banyarwanda.
So 7 Rwandese.
Yes.
And then 1 international.
Yes.
Who is Nubutare.
Yes. So that's 8 neurosurgeons.
That's 8 neurosurgeons.
For a population of 14 million
of 14
people.
million.
Now, as a doctor, right? So I if someone does the math, 8 neurosurgeons, 14 million Rwandans, that's a crazy proportion
It is.
of people who need your services. So I'd like to ask you, as a doctor, how do you handle the amount of patients who need, your help, who need your skills to stay alive? And as at a human level, looking at the needs of service, how do you even justify, for example, taking time off when you know that being at work, being on call is literally might be the difference between life and death?
Yeah. So I think I'll first put some numbers so you understand. So we're saying 8 neurosurgeons for 14 million people. To give you an example, the World Health Organization will tell you to have at least 1 neurosurgeon for 100,000 people. Okay, so 8 per 14 million is what? 1 to 1.7, maybe 1.8 million.
For one neurosurgeon.
For 1 neurosurgeon. So for us to, to bridge that gap, maybe let's say, so that's what? That's 14 million divided by 100,000 people, which, will bring us to maybe 140 neurosurgeons that we should be having to be able to bridge the gap. And
so what you're saying is that where we are today, we have 8.
we have 8.
Where we should have, according to the World Health Organization, is at least 180.
140.
140.
Yes. So the deficit we have is maybe 140 minus 8 is 134. So you can imagine the amount of, of work that is out there for us.
Yeah.
But what, makes me, more happy, it's not being happy because there are patients that are not getting the care, is that when I think that maybe 10 years ago, there was just maybe one, just one,
For all of us.
For all of us, and no one, receiving any care at all. So we've, from maybe 2007, that was the time we had our first Rwandan neurosurgeon.
Really?
2007. So that time we had like 11 million, maybe 11 million. So we've grown,
But then
we've grown, but we still have a long way to go, but we've grown. Okay.
Yeah. I'd like that. But how do you, but there's where we've come from, and there's, what you've said. I mean, before 2005, we had no neurosurgeons, right?
Yes.
So that's good. I'm more interested in understanding how you actually perform.
Yeah. So that's where I was going. One of the good things also is Rwanda is a small country. So you can basically get anywhere, maybe let's say in 3 hours. If you're in ambulance or, the ambulance will get to you and maybe take you to the city, maybe in 2 hours and so. One of the biggest challenge that we had in the past was being able to even diagnose those kind of patients that need our care. Because that time, when we talk about one neurosurgeon, we had probably one single CT scan. We had no MRI until 2010, and everything was located in Kigali. So you understand that someone who has, let's say, a bleeding in the head after a road traffic accident
In Rusizi,
no one will know, They will just see him being in a coma, maybe seizing and being not good, but they will not know what he has actually. So you will need to bring him to Kigali, take him to King Faisal if he's not dead, and do a CAT scan on him and see what he has, if he's still alive, and be able to save him. But remember, that was one person who was doing that job. So it was crazy. Now, I was saying that the country is small, it's pretty small, but also the Ministry of Health has worked very well in putting more CAT scans in different hospitals. At least I know Butari has CAT scan, Kibuye, Kibungo, several other hospitals. At least someone who is there and who has a road traffic accident can have a CAT scan done on him. And I'm happy when I see, let's say someone coming from Kibungo, they call me with a diagnosis. They know what the patient has. We'd like to send you this patient who has this and this. So it's not sending him for me to perform a CAT scan on him. It's sending him with, a clear diagnosis, and I know what to do. And I tell them, yes, send the patient, we'll take care of him. So you see, things are improving a little bit, but I think we need more CAT scan in different parts of the countries, because otherwise you will not know what those people have. And we need to educate the population, but also the doctors who are working in those areas to know how to diagnose or how to make a clear assessment of someone who has an injury, let's say, or someone who has a condition in the brain that needs care or needs attention that needs to come to us in Kigali. So, there are multiple tests that you have to, to have performed to be sure that, I have the accurate diagnosis. This person needs a neurosurgical care, and I need to send him to Kigali, to Sashka, to Kanombe, or to King Faisal.
We'll continue. As you're probably aware, every conversation we bring takes time, research, and sometimes plane tickets. We do it because we love sharing stories that matter. If you've enjoyed what we've built and want to help us grow even further, you can now support the Longform directly. Feel free to donate to our Momo code 95462, registered under LF Media Limited. Every contribution, big or small, helps us go even further. Thank you. So if you know, where do we actually have these services? Where do we actually have our neurosurgeons? I know you're in Kanombe Military Hospital.
So I'm in Rwanda, military in the referral teaching hospital,
That's
which
in
is
Kanombe.
Hospital, military hospital. We have CHUK, CHK, University Kigali. Oh my God.
Yeah, CHUK.
CHK, Centre Hospitalier Universitaire de Kigali, because that's a French name actually. And we have King Faisal, but most of these people who are using Mitwell and Butare, I was forgetting Butare because since maybe the last 2 years we've been having neurosurgeons allocated in Butare. Those were, so we had one Ethiopian who has been serving there for probably 1 year and a half, and we've had 2 neurosurgeon from Cuba who came through the cooperation with MOH, but I think they have left. So you see that, all the patients that were coming from Butare to go to CHK, they are now being treated on site. But you understand that he's alone. He cannot serve everyone.
One person in Butare.
He still needs to refer to us some of his patients. So neurosurgery is provided in the 3 main hospitals, CHK, 4 actually, CHK, CHUB, which is the Butare Teaching Hospital, Kanombe Military Hospital, and King Faisal Hospital.
So let's try to understand the scope of the work, right? You've given me a very, it almost sounds like a medical diagnosis, but let's actually, in a real world examples, like you've said, there's only about 8 of you in the entire country. Obviously, you're probably dealing with per day. You've actually informed me before that, sometimes you're dealing with up to 30 to 40 surgeries.
A month, yes.
Yes, a month. That's literally 1 a day.
That
could be 1 a day, sometimes 2 a day, and that's just
2
you.
a day, or even 3 a day.
Yes.
Sometimes.
So how do you manage that? Is that normal? Is it and how do you actually manage that? There's only 24 hours in a day.
Yeah.
How do you pick and choose who gets treatment? How do you pick and choose who the priority is?
Yeah. So the work is sort of organized in a way. So I will put it in this way. So you have all emergencies. So those are people maybe who have car accident, they're in a coma, they have a bleeding in the head, they're being brought to the hospital. But emergencies are not just people who have accident. You may have someone who has a brain tumor that is pressing on the brain and he's getting in a coma. It sort of becomes an emergency as well. You may have, what else? Someone who has a degenerative disc that is extruded and is paralyzing his limb. That becomes an emergency. Or he's not being able to control his sphincters or PE or, know. So those are kind of emergencies we get. So in my hospital, Butare, or anywhere else in the world, you will have emergencies, and then you have what we call elective. So elective are the cold case. Those are the cases you see when you do the clinics or the consultations. So when you do the consultations, each one of us has at least 2 days per week where we go. We are in a room and receive a certain number of patients who are referred to us to seek care. So those patients, I would say, they're relatively stable.
So they're not about to die.
They're not about to die, but they have conditions that may kill them. But they might die next month. Buy some time. Yeah. Yes. So you see them sometimes, as I was telling you. Now it's good to see some of them getting to us with a clear diagnosis. So they've had their CAT scan done, they've had their MRIs done outside, and you have a clear diagnosis. And they'll tell you, oh, I've referred this patient because he has a brain tumor to you for surgery. And some will still come to us. That's a proper referral because you have made a clear diagnosis and you know who you're referring to. And then you have the patient in between because not everyone understands what we do. So we still need to teach the other doctors when to refer to a neurosurgeon. What are the conditions we need to see? So you will have some patient in the middle who will come with symptoms, but they have not been investigated yet.
Yeah.
So you still need to investigate them.
And
And
then
you have
the
time,
other
you
ones.
you do the CAT scan, you do the MRIs to figure out what they have. And then every day, you have the emergencies. They are coming in nonstop. And you don't get to choose. If there's someone who needs surgery, you do it. Immediately. It's not like sometimes immediately, because other disciplines, surgical disciplines, are operating as well. So sometimes you may need to wait for a theater, availability, so and so. But so we have priorities. When we started back in the days, we were fighting a lot, to tell them, oh, this person has blade in the head. I have to go in right now because like in the coming hour, maybe he might die. So it took time to convince our colleagues and to show them. And, there are clear guidelines worldwide to know when to perform actually surgery. So there are a certain number of conditions when they tell you when someone has this condition, it has to be operated, let's say, in an hour. Like someone who is bleeding. It may not be bleeding in the head, but he has a femur fracture and it's bleeding. You can actually lose all your entire blood just bleeding from a femur. So those are kind of surgeries you have to do right away. Or someone who has a bleeding in the belly or something like that. You have to go in and do something. Or someone who is bleeding in the head, sometimes you have to go in and do something. So those are like life-saving surgeries. And then you have some other surgeries that can wait few hours, but you don't want to wait long. And then we negotiate depending on other emergencies from other disciplines. If you have your colleague who has, a more emergent case, you may let him go an hour or two, and then you negotiate to have the slot next. And then you have a patient who can wait maybe a day or 2 days, but you still need to do them. Those who can wait are the patient we get from our consultations, because we admit them. We call it elective. It's like a planned surgery. I admit them. I say I will do them maybe during my given time where I do cold cases. Yeah.
Do you ever? So it almost sounds like, okay, so you immediately see someone, and then I wouldn't say that you're almost playing God, but it's almost like you're playing God, because now you're saying, okay, this is who you are. I believe you are in this category, this category, this category, this category. And based off of where I've put you is the speed in which I will get to you.
Exactly.
Now, don't you ever worry, or has there never been a time where you made the wrong categorization? Then, for example, you say, this one is not 100% emergency, so maybe I'm going to see him 7 hours from now.
Well,
and then between those, you actually, between that, you realize, oh my goodness,
okay,
this has been, I've made a mistake here. And then you end up potentially losing someone. Has that ever happened?
Well, I would not say that way. I would say that, the good thing with these big teaching hospitals have guidelines, like clear guidelines. You receive a trauma, there's a way you categorize him, like straight away. And, so we call it A, B, C, D. A is airway. Is he breathing? That's literally the first thing to see. Even if you're bleeding in the head, that's like D. D is disability. So you see, you have to go through A is breathing, or airway clear. B is breathing, circulation. Is he bleeding anywhere? And then you get to D. Okay, and after all of that, you can categorize your patient, and you know how quick you have to intervene. And then you have other patients who are sort of, so the patient you're talking about, sometimes they come in borderline. It's not like there's a clear indication of doing something right away, but they may deteriorate like in a day or two, and you don't know. They may deteriorate or they may actually improve. And it has happened that, the person you say, okay, I'm going to observe him, like let's say 24 hours, you see that he's losing consciousness, and sometimes we intervene very quickly. It's not like we let them deteriorate. Sometimes some patients are borderline, and there's no clear cut, clear indication to go in, and you have to wait, and they may go down or they may improve. It happens a lot.
Today, did you go to? Were you working today?
Yeah, I was there.
So this is Friday.
So yeah.
We're recording this at 5 p.m. So you've come straight from the hospital, changed a bit. Obviously, you're not in your scrubs, and now you're here. How many people did you operate on anyone today?
So today, Friday, my hospital and our neurosurgery unit is organized in a way that Friday is set for teaching our students and for doing a general ward around. I actually have 2 pending surgeries that are being done in the hospital right now. There are 2 emergencies as we speak, because I have a team, so the team can do some of the emergency cases. The team can handle them when I'm not there. So in the morning, let's say I come at I'm in the hospital maybe at 7:45. We have a meeting with all the surgeons at 8 till 8:30, and then I meet my colleagues. So we round on all our neurosurgical patients from the ER, so that's emergency room, to the ICU. We have a lot of patients in the ICU. We go in the wards. So the wards are the rooms where the patients are admitted in. We see everyone, we look at the plans, we see the ones we've operated on, maybe we discharge some, we see the ones we have not operated on, and we plan to operate them, because we have 3 slots in a week. So each of us operates one day. Those are the cold cases. And then we get to operate every day, because you don't get to choose when emergencies are coming, right? So I would say that we do surgeries almost every day, but I can do my cold cases at least once a week. So sometimes it's not sufficient, because when I go to my clinic or my consultation, I recruit people, I will see at least, let's say 30, 35 patients. Among the 35, there are at least 5 patients that need my care, that need to be operated on, and I need to find a time to do them.
How do you do that? How do you manage? Like I said, it sounds like you and your colleagues and our system, you have a way of making sure that things don't overwhelm you, but it does seem a lot.
Yeah, I will not say, because if you look at the numbers, I will still say that probably most cold cases don't get to us on time, or don't get to us at all, because people maybe will stay home when they have a headache, or when they have a seizure. They will not seek care until it's too late. The ones that really come to the hospitals are the ones who either had an accident or they're in a coma. And so now, in these days, we're seeing more patient consulting, for a headache, because now people are aware that you can have a growing in the brain that can kill you. So I see that the population is more aware of the brain conditions, which is good. So they will seek care for a simple headache, and we get to diagnose some of those cases that will probably go unnoticed for many years. So
the work is
I would
a lot.
say that the work is a lot, because if you say, yes, each one of us has at least 100,000 people, and each of us is supposed to handle 1.7, and we're not even handling 1.7. So where are the rest? So now
looking at that, right? So I have I know a few people who have demanding jobs. I don't think they're as demanding as you. And one of the hardest things for them is going on leave. Because they always feel that, you're letting the team down. Now, for you, it's not even about letting the team down. It's literally you're letting someone potentially pass away.
Yeah.
How do you justify in your head? How do you make peace with the fact that you need to rest? How do you make peace with the fact that you need to maybe go on vacation and take your leave?
Because I will not take care of you if I'm dead, right? Right? I think we've come to that. We've come to accept that we need to take care of us, to rest, to sleep enough, and to recharge. So when I started at the military hospital, I basically worked alone for almost 2 years. It was very...
By yourself?
By myself. So patient will come in and, when I needed to take a leave, patient were sometimes redirected to Seashika or King Faisal Hospital because somehow I needed to rest, okay? And then the team grew. We're now 3 of us, and we have a roster we organized, and we make sure that each one of us, takes his days, go and rest, see family, travel if you want to travel, but recharge, and come back. Because if someone is tired, there's no how we're going to help the population if we're not helping ourselves.
Yeah. How many days of leave do you get?
Like any public institution, I think each one of us has 30 days.
30 days.
Yeah, 30 days.
Do you actually take your 30 days?
I do. I make sure I do.
All of them?
Yes, I make sure I do. Sometimes, like in COVID, you could not even take, days off. So, they are ended without even taking a leave. But they allowed us to take our days from the previous year, which was good.
And do you fully switch off?
So it's not like switching off. For me, I've never been able to take all the 30 days. I can be gone for 2 weeks or 3 weeks just to help my colleagues, because if I leave my colleagues alone, sometimes the other one may be gone, but you also need to go for trainings, you need to go for conferences because you need to keep sharpening your knowledge. That's also important. Like for instance, every year we renew the license of practicing, and among the conditions for renewing our licenses is we have participated to conferences, we've given talk and what. So that means that, yes, you're a doctor, you've been there, you've gotten there, but you still need to know what's going on in your field. So it's advisable to go to conferences, to go to meetings, and so. We also teach, so you also need to go, you have that time you go to teach, sometimes you're off because you've gone to teach. So we organize ourselves. I will not leave my colleague alone for 1 month, it's too much. Maybe I can be gone, let's say I can be gone 3 weeks or 2 weeks, and then I need to come back so they can, we can help each other.
Continue doing the work. This is a question. So by the time someone appears on your operating table, now you're no longer doing the rounds. They're now on the operating table.
Yes.
By the time they've reached your operating table, things are not going very well. They're literally often moments from death.
Yeah, right.
Now, through your training and actual God-given talent, you are able to allow them to spend another day on earth, right? Just literally those two things, training and just your good God-given talent. Now, that's a lot on you.
Yeah.
Like literally, you are I do podcasting, but fundamentally, I'm not important. If I stopped today, life would continue for everyone. Some people would complain that there's no content anymore, but content is not important. Yeah. The work that you do every day, that's important. That keeps people. It allows a mom to enjoy her children. It allows children to grow into adults. It allows soldiers.
Yes.
To fight another day.
Right.
So I'd like to ask you, how do you mentally and emotionally deal with things when someone passes away? You know, when you do your best, but despite your efforts, things don't work. Do you get feelings of regret? Do you end up having nightmares and or do you question if I should have done something different?
Yeah.
Do you question yourself? Do you question yourself as a doctor?
Yeah, you do. So the good thing is, so you've been in the training, you finish. So they have a way of calling you a junior consultant. Those are like the first 2 years. Like the first 2 years, sometimes, you still doubt of yourself, you're doing stuff because they've given you the license to practice and go and do. And, sometimes, you don't know, and, you're seeking advice and you're asking people, and you keep growing that way. So the more patient you see, the more experienced you become. So I'm in my 7th year. So you can imagine, it's not like I've seen everything, but I've seen most of the stuff we do. I know patients. So the good thing is, as the more you go, the more cautious you become. Like when you finish, you have this, you want to do everything, you're jumping on anything and everything, but the more you grow up, the more cautious you become, and you can predict some complication. Let's say I take someone who has a tumor in the head. I know, is this cancer or it's not cancer, and depending on how they are or how they got to me, I say, this patient may have pneumonia after, this patient may have a clot that goes to the head after, like obese patient, they tend to have more complication postoperatively, or like patients who have diabetes or other conditions, you expect them to have more complications. So you are more mature, right? So you can predict, or you can have a sense of what might happen. And it's like, every time I go in the operating room, I go with a mind of saying, I'm here to do my best. It's not like I came here to fail. I came here to do my best to save this person. Now, if I have a complex tumor or a complex person, I know this and this and this and this, based on my experience, because I'm more mature, might happen. And sometimes the things you're predicting happen, and sometimes may lose a patient. Not because it's entirely on you, but because it is described, right? Those kind of complications can happen. And these are among the things you discuss with the patient and their families before you take them in. You basically tell them, you might die from anesthesia.
Jesus.
So there is a chance that you might actually die when they give you anesthesia. Before I even touch you might die. There is like a 0.000 something chance of dying on tape. You discuss, but I'm going there to help you because you need help. I like to operate patients who have gotten there in their mind, like they trust me, they made peace. I make peace myself, and everyone goes with a positive mind. And I find that those kind of patients do well. It's a patient who is still doubting, and you still need to do him. And sometimes when they have complications, it's so tough to make them accept. Like let's say you operate on them, they have paralysis post-operatively. They might say, okay, no, look at this now. I came in, yes, I came in working, now, I'm paralyzed. But those are some predicted complications. I believe and I think if you go in ready to give 100% of yourself, and the patient is ready, God is there too. Because there's some stuff I don't understand. I will see patient who comes from, I don't know, Kirehe. I never seen them, Is a muturage, spend time working, go Nyabugogo, something like that. I spend the night in the how do you go, in the bus station, to be able to be in Kanombe on time. I get to see them. I diagnose them. Some of those patients have very complicated diseases. You wonder, am I going to be able to cure this person? But because they come with that positive mindset, that this Muganga is going to help me. It's incredible. These are the patients that do well. More than the people who are like
super smart,
smart and everything.
Yeah.
We're actually more scared of the super smart people and doubting people. But the Muturaje will get you peace in his mind, puts all the trust in you. And when you're helping him, you're like, I don't know this guy. He has a thing that I can solve, maybe. God help me. That's what I always tell God. And I'm so happy to see each one of them. When they wake up, I've removed this so-called cancer or tumor in their head. They're working, they're going home. I'm like, that's a life with a purpose. Like, my life has a meaning.
Yeah.
I may not be the richest man or the richest woman on earth, but I've given back a life to someone I don't know, someone whose parent did not call me, someone who just came with hope that I can help them.
That's, that you're saying that, and it I guess that's the thing with you end up with these emotional highs.
Yes.
But then it almost sounds like you trained yourself not to get those emotional lows.
Well, so because these people come to you and you're the last, let's say you're the last person to help them. So are you going to run away or you're going to face it? And as you mature, as I was saying, you get a way of explaining to them. More educated people will question you. They want to understand. You have to find a way of making them understand their diseases, the care they need, potential complication. It has to be put on table because those are the ones who will question you when there is a small complication, like why this and this happened. It's not like saying that the Muturaje do not question. I just feel like you need to treat, and I find that the Muturaje understand. When I take a Muturaje and I tell him, this is your brain, this is the lamp in your brain, they understand. They understand.
So 2 years into your practice, you said that, you used to think you were a superhero.
Well, it's...
And no, I'm not saying that it's a bad thing. I'm just saying that that's what you said, that you kind of learned, you were very excited, you felt that, and it's something that I've seen with young people, right? You believe that you're immortal.
Yeah.
You believe that you have all the answers. And then I think as you get older, you realize that you are just human as well.
Yeah, right.
And then it's a bit easier for you to deal with crisis or tragedy because you understand that that's just part of life.
Yes, part of life.
How, when you were still a young doctor, how was it like to, because you come in, you feel that you're the one. How did you feel when Superman or Superwoman in your case, could not fly, when things did not work? How did you deal with that?
Yeah, I think that's what humbles you, brings you back on earth, and just reminds you that you still have a lot to learn. Yes, you went to school. Yes, you have all these degrees, but life is unpredictable, and each patient is different. You might have the same disease in different people, but they behave differently. This one will have more infection. This one will do well, and you just learn. You learn from your own experience and from your own failure.
Yeah. No tears. You never cried.
Well, I used to cry when I was a young resident, like first years.
Yeah.
So it was scary.
Yeah.
I remember that was the time I lived in Morocco. The calls are crazy because they have a lot of assaults and everything. You're basically running in the ER. Everyone is running, and you have even assault who is trying to assault the medical personnel.
Yes.
So everyone is running, and everything is crazy. So I used to get scared. I was like, oh my God, I'm going to kill this patient. I'm going to. So the more you do, the more confident you become. And we train for many years. Almost when you are in your 6th year, and you're when you say you're a junior neurosurgeon, you're almost like in 8th year of practice. You've almost seen the things that are supposed to make you go crazy, right?
Yeah.
So you're more calm. I think you're more calm. And then you're tackling the more complex pathologies. So the more complex pathologies, I've seen even the best neurosurgeons, my former mentors. I had a mentor who had like 30 years of experience. He's been doing tumors his entire life. But taking one tumor would scare him. So I saw him being scared.
Why?
Because he was like, every patient is different. And then he will like, oh, we need to do that and that. So that's what you learn as you grow. He's like projecting at all the complications. I didn't understand that when I saw him panicking over one patient. Yet he's the Superman. I'm like, why is he panicking? But that taught me that, Claire, you still have a long way to go. So this guy is basically, people fly to come and see him. And he still panics for one patient. I don't even have, like 1 year of practicing experience. So I have my entire 30 years of panicking. Yeah. So I was like, chill and do what you have to do.
So no panic.
No panic.
Now, I want to ask you, so you've told me that you do about 30 to 40 medical procedures every month at the military hospital. Now, out of all these surgeries, right? Because now I want to have a sense of actually what are the causes of all your work.
Yeah.
So out of all these surgeries, if you were to look at in terms of proportions, what is the leading cause
Trauma.
of traumatic brain injuries in Rwanda?
So everything we do, as I said, is not trauma. Okay? But the leading of everything we do is probably trauma, because trauma is like overwhelming and it's crazy.
So when you talk about trauma, for people who don't understand medical words.
Okay, how can I? So these are people who probably have road traffic accident, fall from height, being assaulted, and they have an injury. It can be on the brain and can be on the spine. So you have what we call head injury. Those are the injuries to the head. And then you can have what we call traumatic spine injuries. So those are people fall from height, break their bones in the back, get paralyzed, or from car accident. So those are the trauma. Okay, we call them the trauma. And even trauma is a broad word. It can be used. So you can have trauma everywhere on your body. You can have abdominal trauma. You can have limb trauma. So those are trauma to the either head or spine. Okay, those are the majority of our patients. I would say like 80% of what we do is trauma. But remember, maybe if I try to categorize all the neurosurgical conditions, you don't only have trauma. So let's say the trauma, head and spine, and then you get to have degenerative spine disease. These are people who have, you've heard about it, disc prolapse, disc herniation in the lumbar or in the cervical spine. It's called degenerative spine disease. So it's basically your spine that is getting old, and some of these discs may protrude and make you being paralyzed because they are compressing either the nerve roots or they are compressing the spinal cord. Okay? And then you get all the tumors, as I was saying. So the tumors can be adult in the adult population or in the pediatric population. And you get all the strokes, hemorrhagic stroke, we did not talk about that, or vascular malformation. So vascular.
But I'm asking if I can, because we're going to talk about all these things, but I want to talk about a very specific thing, and that's traumatic brain injury.
Yeah.
So
I just wanted to put all the causes the people will consult us, or including the ones I see when I do my consultation, and the one that come through the emergency and tell you the trauma, which are probably the most common,
Yes.
because they come every day. But if you look again at the numbers, even the cold cases, there must be many. It's just they don't get to us on time. If you were, like, there are probably procedures we're not doing on time because those people either were overwhelmed with trauma, but we still need, if I see 35 patients and I have 5 every week, so at the end of the week, I have like 20 patients queuing for me to fix them. You see? That's also a big number, but it's being overwhelmed by the trauma, because the trauma is you have to do something right away. So the ones that can wait, they still wait until we find some time to do them.
With the traumatic one.
Yeah.
So what is the leading cause? I'm going to ask you again. In your experience, what is the thing that brings many people to your operating room? Because removing people who maybe have degenerative issues, maybe removing the strokes, because those are things that kind of happen over time. But when I think about traumatic head injuries, I'm thinking about, like you said, accidents, car accidents, falls and what?
Assaults.
When and assaults, like someone has fought with someone. But I think the reason I'm asking you this question is because I want to understand the scope of the real work that you do and the cause of the work that you do. So is it, because I was wondering, I was like looking at young people, looking at how they travel on, for example, motos. I think, look, I've seen, I had accidents, and in my thinking as just a layman, I'm thinking that those are probably the majority of.
Yeah, absolutely. So the motors, bicycles, they're probably the majority. So most of the motors, if they're wearing the helmets well, they'll probably protect their head, because it's proven that wearing a helmet and wearing it well will prevent those head injuries. But, we talked about it. We've seen people basically having the helmet hang there, or the women who are taking it as they're on them. So that's very dangerous, The strap is not fastened, or, it's not fitting the head. So when you get ejected or when you get hit, you get ejected and the first thing you do is you hit your head somewhere, or you break your legs, but the head injury is more severe compared to the legs and everything.
Thank you, Kigali Marriott Hotel, for providing a venue for the long-form podcast to record. At the heart of Kigali's hospitality, Kigali Marriott offers everything from luxury stays to premier event spaces, fine dining, and top-tier conference facilities. Keep up with them at Kigali Marriott on socials and visit their website, www.marriott.com. How many of those ones do you see per week?
Per week, I think, so the traumas we get to the table are the ones who have a bleeding that is compressing the brain, that, that needs to get out. But you also have the ones that you don't operate, like the ones who have a bruise. You keep them for observation, but they have a bruise on their brain, So there are many. So if we say we do maybe 2 surgeries a day, every day, let's say, at the end of the week, you've probably operated on 10 people, but the people you've seen that have all the trauma to the head are more than the 10 you've operated on. So they can be even 20, because there are a lot that had maybe like a mild concussion, is when the brain just shakes, or the ones that have the bruises, you don't need to open them, or so if you count them, there are many per week. There are many. There are more than 15 per week.
Do you ever go on motors?
No, I don't.
Why?
It's been because like most of my clients they fall on a motor. So me, I'm like, no. I think the day I go on a motor, I'll have an accident for sure.
Yeah.
Yeah, I'm like, no. And I think the motors, they try, right? Really, like they try. At least motors here are regulated. Because if you go to other countries, they're not even wearing helmets. What scares me the most is the bicycles. And there are many. There are some neighborhoods where, you find more bicycles. So just imagine the bicycle is more higher than a motor. When you get hit, you get ejected, and you're not even wearing a helmet. And that's something that needs to be done for sure. So because you break your head for sure. And the kind of injuries they get, very severe injuries. Very severe injuries. But again, to make MOH do something about it, it's up to us to bring out those numbers. Like do studies, show them actually we receive, this many, all the hospitals combined, and we recommend that probably you tell all bicyclists to wear a helmet, or we create roads for bicyclists or moto that can be thought of, because the accident. And when you look at the young that are being involved in this road traffic accident, these are young male, 20s, 80s, male, predominantly.
Why?
I don't know.
Maybe it's because actually
because
the majority.
the majority are male.
Yeah.
Like the bicyclists.
Motors.
Yes.
It's male.
Motors are male. So you get maybe motors passengers, female. Yes. But most of them young male,
I guess I had actually thought about motors quite a bit. I hadn't factored in bicycles.
Bicycles are more dangerous.
In my head, because they're much slower.
No, they're not much slower. Because look at the bicycles. Have you been at maybe Nyamata? You see them coming down.
Yes.
The speed, it's crazy. You see, if this guy get hit, he's going to go somewhere. Yeah.
That must be tough.
Yeah, it is tough. Because with a motor, maybe you get ejected, but at least most motor passengers or they are wearing helmets. In a way, they're wearing helmets. They may not be wearing them well, but they are wearing helmets. But bicycles here in Rwanda, they don't wear helmets. And I think it's a road that we have to.
I agree.
Yeah.
I agree. So, you don't only deal with, motors and bikes and, people getting hit with hammers on their heads. You also deal with, other brain issues such as strokes and brain tumors. I'd like to ask you, as an expert in the field, is there anything, and I'm going to ask this question as it's almost a selfish question, because I'm now thinking about myself,
right,
and making sure that I'm not someone who I want to avoid you. We are friends, but I want to avoid you as much as I can.
Yeah.
So are there things that I can do, that a healthy person can do, whether in terms of diet or lifestyle choices, to keep our brains healthy, to avoid strokes, to make sure that, tumors, either don't grow or stay small?
I'll break this into parts. Okay. Stroke and all the cardiovascular or anything that is related to the vessels that going to the brain or to the heart, because it's almost the same disease. Those are somehow preventable. Okay, there are stuff you can do to prevent them. Okay, because strokes sometimes, and most of the time, come from, let's say, uncontrolled hypertension and control diabetes and all the diseases that the Ministry of Health keep reminding us, the non-communicable diseases. So there are diseases that are not transmitted, but come from our lifestyle, right? The way you eat, what you eat, your weight, do you exercise, do you rest enough, so and so. So those are things you need to make sure you're doing to make your health healthy, to avoid the strokes or the heart attack. Okay?
So it's the same thing.
It's almost. Those are vessels, big vessels that are, going somewhere. You probably have 3 or 4 important organs. You have the brain. I think the brain is number 1. You have the brain, you have the heart, you have probably your pancreas, which is very important. You have your kidneys, your liver. So those are like very important organs that you need to keep healthy. So if you look at some of the behaviors, like drinking, smoking, overweight, so those are the stuff that damage those organs. So when they tell us, go out, exercise, control your weight, control your diet, we are preventing those non-communicable diseases. So I will put this straight away. There's nothing you can do to avoid a brain tumor.
Really?
The brain tumor can come to you, can come to me, it can come to anyone at any time, and it does not choose, right? It does
so you
not,
can almost control a stroke, you can't control a brain tumor.
So you cannot control a brain tumor. You may have it, I may have it, someone else might have it. Of course, there are brain tumors that run in the family.
Really?
But they tend to be the rare ones. They're not the most common ones, right? But they can run in the family.
Like genetic?
Like some genetic diseases that can make people have brain tumors. Okay. But that's not the most common brain tumors. Okay. I think we talked about it. Like the most common brain tumors, sometime you may avoid them in a way, or you may do something about them. So the most common brain tumors are meningiomas. I think I told you about them. So the meningiomas are like, well, how can I call them? Oh, they're like small, or sometimes they grow very big lumps that are not in the brain, but they grow in the cavity, in the brain cavity, intracranial cavity, but not in the brain. And they push the brain. And they tend to get localized in very critical areas, like around the vessels, around the nerves, which makes sometimes the treatment very complex or very complicated. Okay? Now, these tumors, it's very weird, but they tend to attack women than men.
Really?
Yes.
Why?
So they are hormonal dependent. Okay? Most, I would say like 90% of these meningiomas, they have what we call progesterone receptors. And the progesterone is a hormone that is, secreted in female. And then some of them, like 20%, are estrogen, also found in female. So the meningiomas will attack women at least 3 times more than men, but some men may have meningiomas. And, they tend to grow when you're taking some hormonal replacement, may make them grow.
When you say hormonal replacement, what do you mean?
So hormonal treatment. So maybe there's some contraception now. There has been links between meningiomas and contraception.
So you mean birth control,
progesterone.
So birth control pills that are rich in?
Pills that are rich in progesterone may make female, let's say, who have small meningiomas grow big. Or pregnancy. When you have a small meningioma, it tends to grow faster when you're pregnant.
Is there any way to know that you have that thing before it becomes a problem?
Sometimes, because they're very slow growing and they're compressing the brain, and brain has this capability that we call neuroplasticity. It's like a you can push the brain until it feels like I cannot handle it anymore. And that's when it will start giving you symptoms.
So it's like you're almost saying that the brain can contract.
It's not contract, but it can be pushed to the extreme. Okay? As long as it's not infiltrated or invaded, it can be pushed to the extreme until it says, I cannot take it anymore. And it will start giving you more visible symptoms. But when you see this patient who have big meningiomas that have been growing over many years, and you ask them or their families, you may find some subtle symptoms that have been there for many years.
What symptoms?
Like personality change, because let's say if they are located in the frontal, so that's the forward part of the brain. It's the part that controls behavior. Okay, so the person will not have a paralysis, but they will probably be more angry, yell at people, and people think that they are crazy. Yet they have something that is growing in the brain, right?
I mean, I've heard of that. Like all of a sudden, someone who used to maybe be this kind of way, all of a sudden just becomes a totally different person.
Someone else. Yeah, I've also heard like couples almost at the age of divorcing. I think you've heard about Bruce Willis before being diagnosed. They almost were going through a divorce because he had become someone else until he was diagnosed with dementia, right? So the tumors that are located in the frontal lobe, they will give you those symptoms, subtle symptoms, personality change, and they're growing very big, very, very big.
How big is the biggest one you've ever seen?
10 centimeter.
10 centimeters?
Like a 6 centimeter.
Like a tennis ball?
Like a tennis ball, or more than a tennis ball.
In someone's brain?
In someone's brain. So that's the neuroplasticity. The brain has that capability of being pushed until the extreme. And then, when it's, getting more bigger, it will start giving you more symptoms. And it's because of those symptoms that people actually consult. So the person will start having seizures, or they will have trouble seeing. And most patients, which is sad, will get to us when they are blind. It has been so big that they lose sight before you can even bring back the sight.
Are they getting headaches? Like, how does someone? I'm interested in that. Like, so again, I want to make sure that myself or listeners to this are able to know what is happening to them, right? Because we don't want. I would not want to come and see you when I'm blind.
Yeah.
But sometimes you've had a long day and you have a migraine. How do I know that it's a migraine and not something else?
I think different kind of headache. You can know what type of headache you're having. Like migraines tend to be one side, or cluster headache. This is what we call cluster headache. Is when you have a headache and then you have a red eye, and then you have the headache that comes from a tumor that is compressing the brain is sometimes a headache that is constant, not responding to medication. But as I tell you, it's uncommon that patient will not have other symptoms. If you trace well, you find some subtle symptoms as well.
So
like
headache.
Headache, having seizures. So someone who is an adult who never had a seizure and has a seizure for the first time, that's probably like almost 100% sure that there's something in the brain. Someone who is feeling like numb one side of the body, because when the tumor is located at one side, it tends to give
another symptom.
The paralysis on the other side. That's how the fibers, because the fibers cross.
So wait. So let's go slowly.
Okay.
So a tumor here in the front of the skull, right? So above the, I guess.
Let me make it more simple. Okay, so you have the head, you have the brain inside. Each part, so the brain has different parts. Each part of the brain has a certain function. There's a part that makes you behave the way you behave. That's the frontal lobe. You know, behavior, what you do, whatever. There's a part that is responsible for memory. Okay, most of that part is located in the temporal lobe. It's more here. There's a part that is responsible for movement. It's more the parietal part. So it's more here. So you understand that if you have a lump that is growing here, you will have a paralysis for sure. That's more easy. It's you know, like it gets to express itself because it will cause paralysis. Now you have a vision part. If you have a growing in the vision part, you tend to lose sight, but not sight as in looking at things clearly, but you lose sight in the sides, peripheral vision, okay, or what we call peripheral fields. So you lose some fields. So those are symptoms you need to look for. And then, you know, because I don't want people to panic, and that's also what we're seeing now more, because people will panic. I have a headache. Oh, I have a brain tumor, blah, blah, blah. So I think we should not scan any headache, but we can push to see if there are some symptoms and see if this person really needs brain imaging. But I know that, for instance, in the US, someone will go and have a body MRI, you know, just to be sure that they have nothing growing. But there is a brain tumor, like the most malignant brain tumors, they can grow in 3 months. So you may have a body scan today. In 6 months, you have a malignant brain tumor that has grown.
That's scary.
You know? So I think people should not panic, and every headache run and panic and say, I have a brain tumor. I think the best advice is to seek care, to seek specialists.
Because you've said not every headache.
Constant headache, headache that are not responding to usual treatment like paracetamol.
Constant headache means
it's like
you
wake up with the headache, and they tend, so when there is a compression in the head, they tend to get accompanied by some other symptoms like vomiting, nausea, and then vision is the first thing to see, because the more the pressure grows in the head, you start losing the vision. So that's something that is not, like, I've seen different people when they tell me I have a headache, but I also see double. I know 100% sure that there's something growing in the head.
Yes.
I say, okay, there's something here. But I will not scan every
person.
Headache. Yes.
I guess
because then you panic, right? So then you get what we call incident discovery. Incident discoveries, these are things you see just because you had a scan, right? It's like having, a bump somewhere. It's like having,
So let's create a scenario. So one of the things that they do tell you,
it can be good, it can be bad at the same time.
Yeah, because
if, let's say, I can detect a meningioma that is still, let's say, 1 centimeter. I at least know that it's there. I'm going to educate the person, like it's still, because something that is less than 3 centimeters, we usually do not operate, and it's not even compressing the brain. So probably the headache she's having are not related to the tumor.
Yes.
You see, because there's no compression.
But then now you've caught it, though.
Yeah, but you've caught it, but the patient will tend to panic.
I'm going
they
to die.
diagnosed me a tumor. So then you have to manage those, panic modes. It's like, okay, listen, this is basically 1 centimeter, right? I think recently we've had an old woman who had paralysis on one side. It was acute onset, and then they scanned her first. They see a small lump, a small meningioma, because most women, if you scan us, you'll probably see small meningioma.
Really?
Yes, it's crazy. And it's common in Black people.
Wait, okay.
Because we tend to have these progesterone receptors more than white.
So you can, So are you saying that you can...
If you scan our
go
moms and what, you may find that they've carried meningiomas their entire life.
So you're walking around with little
It's
tumors
like
in your
having
brain.
fibroids.
Yes.
It's the same, almost the same mechanism.
Oh my goodness.
So they are hormonal dependent, right?
Do they become bigger
they're
and
like
smaller?
fibroids of the head. So you don't remove any small fibroid in a woman, right?
Yes.
Unless they're symptomatic. It's the same.
So you guys are walking around with...
Most of us, I believe if you scan the entire women, you may find
at least 50%?
multiple. So the good thing, the more you reach the menopause, they slow down. They don't grow because you're no longer producing hormones.
So you're going to see it maybe in younger women?
Younger women, childbearing, pregnant, multiple pregnancies.
Yes.
Contraception use. Yes, that's the profile.
Huh. Well, that's another reason.
So I was telling you the story about the old woman. They scan her. She has had a paralysis. They find a 1 centimeter small meningioma. And my colleagues were consulting me. I said, the meningioma is not responsible for her paralysis. Look for a stroke. Because sometimes the stroke, when it happens, it may not be visible in the first hours, even if you do an MRI. In the first hours, it's not very visible. I kept telling them. And the family was panicking. Oh, mom has a tumor in the head. I'm like, this is not the cause of the paralysis. We scan again, she has a stroke. You see? So those are kinds of, explanation you have to be willing to give when you incidentally find something.
Is there any food? Because they always talk about like food being they say food is medicine sometimes. Yeah. Is there any food that we can eat that is available on our market? You've already told me, okay, I need to run more, eat less sugar, sleep a bit more, less stress.
Yeah.
Is there? So I don't do it, but let's pretend that I do.
Yeah.
Okay. So first, I have to become a bit more healthy. Is there also food?
Yeah.
That I can eat that will, say, for example, maybe reduce my incidence or likelihood of getting that meningioma, that...
Yeah. As I said, I think there's nothing that can prevent a tumor to grow.
Nothing.
If it has to grow. But as we said, for the,
because you've said for women, there could be a few things that...
A few things, but those are like the pills, right? But pills are not food. Maybe people who are taking contraception, oral contraception, even injection, those may be related, but it has to be a long-term use, right? It's not like the morning pills. It's known that they're not causing tumors. It's more the long-term use of pills that have progesterone. It's called synthetic progesterone. It's called progestin. So pills that are rich in progestin may cause those meningiomas. Now, coming to the food goes with, sleeping, sports, it's basically more like making your brain healthy, not having a stroke or being relaxed or being, having a good memory, having a sharp brain. Yes, there are food that you can eat that can help that, right? Yeah.
Like what food?
Like what food? So I think we all we heard about spinach, right? So those are like usually leafy leafy greens. So leafy greens can be spinach, kale, or collard greens. Those are rich in vitamin K and folate. So as I told you, folates help with the neurons. So the neurons is the small entity of the brain or the nerve cell. So those help the neurons to be healthy. But you also have what they call fatty fish, like salmon, sardines. They are rich in what they call
omega-3s?
Omega-3 amino acids, which help the neuron health as well. We talked about olive oil, avocado, eggs are rich in what we call choline. Choline that makes acetylcholine, boosts memory. We have.
How about folic acid?
So folic acid is vitamin B9. So vitamin B9 help the nerves. It's enters in the neuron health as well. And it can prevent some CNS malformation, like we've talked about. So some women, now it's known, and the WHO has passed a resolution that women who are having kids should eat fortified food in folates, because it's known that they can prevent them from having what we call spina bifida. I don't know if you've seen spina bifida. It's those babies that are born with bumps on their back. It's basically their nervous system did not close properly. So it's like you're having the nerves that are protruding on the back. It's called spina bifida. So if you don't take folate before you get pregnant or in the first 3 months, you have a high chance of having
before
a
you
baby.
get pregnant?
It's advisable, like 2 months, 3 months if you're planning. So you should plan to be pregnant.
Another good
to be
reason.
sure that you at least you eat enough spinach, you eat enough food that has folate, or you're taking folate supplement. And when you are pregnant, the first 3 months, that's when the baby forms. That you form a nice baby.
I had no idea.
And it's sad because we see this in poor moms, more poor moms. Probably their food intake is not rich in folates. And then you have that burden of having a kids whose nerves that controls the limbs comes out, because when you close it, sometimes they are paralyzed for life, and then they tend to have hydrocephalus, is having the fluid in the head. So it's a heavy disease. Okay, those are kids who will never walk normally, who are retarded, and who are born to poor moms. But that's a very preventable disease.
I had no idea.
Yeah.
Now, specialized skills like yours don't just fall from trees. I mean, it takes at least more than a decade to create a neurosurgeon, a brain surgeon. And that's just your skill set. Now, to actually do the work that you do, there's also
the learning curve.
And also the tools.
Yes.
Like you literally need the best technological tools to give you the best outcomes, because you want to have the best doctors with the best facilities. And then you can maybe have the best outcomes, because obviously when you have what you need, you can perform at 100%.
Right.
Now, all of this, countries like ours, we have problems, because having the best doctors who then have the best equipment takes time, money.
Yeah.
And for countries like ours, we don't have a lot of time. We don't have like 30, hundreds of medical schools and a culture of medicine that's 200 years old. Like you've said, the very first colleague of yours was in 2005? 2007. So Rwanda we are quite behind. And like you also said earlier, sometimes you're dealing with, someone has come in and now you're negotiating with someone who's maybe trying to do a cardiac procedure. And now who gets the operating theater?
The operating
theater.
Yeah.
Who gets
the slot?
the slot. That's really difficult. Now, I would like to ask, so technology sometimes allows us to leapfrog. Back in the days, Rwanda we did not have a lot of telephone lines. And so access to telephones was very, very rare. I mean, back in the day, you remember those kiosks that we had to go to make a phone call before. But then we were able to leapfrog that by getting mobile phones. And then all of a sudden, because of technology, access to telecommunications and communications became easy. Now, I want to understand our Rwandan context. And what are the things that we can do to leapfrog our own technological constraints, our own, human resource constraints? Is AI the magic bullet? Is it robotics that will allow you to finally have a bit more rest than you have? What tools are available to allow us to actually get the kind of service that you can maybe receive in New York or Los Angeles or in London?
In your surgery?
Mm-hmm.
Well, it's I don't know. It's not an easy question.
Yeah.
Well, so if you go back, right? What was preventing, for instance, Butare from having a neurosurgeon on site? Easy. Not having a CT scan.
Okay.
Because not being able to do anything because you don't know what's happening, right? So you at least need to do some imaging, know what's going on, and then you can perform some surgeries, right? So the time they had a CT scan, they could diagnose the so-called head injuries, and someone could do something on them. And then here in Kigali, we have scans, we have MRIs. But again, neurosurgery is a field that is evolving, and we've talked about it. We need precision. So it's not like we're back in the time where you say, okay, I'm going to remove that tumor, I'm going to make a big cutting. Now people will come and say, I want a small cut, precise, and I don't want to see the scar or anything. And we need to get there, right? And sometimes, as I was telling you, like the meningiomas, they are not cancers. They are like lumps, benign, like we call them benign. They are probably not going to kill you, but they're going to grow. And when they grow, they will, take all your vessels, nerves, and make you blind. Let's take a big meningioma that in case the carotid artery, which is the main vessel that feeds your brain, and takes your optic nerve, which is the main nerve that makes you see, and you want to remove it. So you want to be precise. I think if you're in the US or in any advanced countries, they will tend to use what we call the navigation. So the navigation tools are like GPS. It's like you know exactly where you're going. And, you can trace that road and saying, oh, I'm making the cut here, I'm going there, that vessel is entering here, that nerve is here, and you can imagine that tumor and remove it safely. And that makes you do a more safer surgery than just go inside and try to look for that, right? But you can still do that because that's classic neurosurgery. And all the neurosurgeons, they've done very nice surgeries without all the technology that is out there nowadays.
But now there's technology.
Now there's technology, and you can be more precise. And I think we have to embrace it. So if I can be more precise on where I'm going, if this technology can show me where I need to go, I think we need to embrace that. It's going to add something that I'm probably not going to be able to do with my hands only. So it's adding. It's like augmented reality. We talked about it. That's why they call it AR, augmented reality. It's like, yes, you have the hands, but you have also this roadmap that is well traced for you. And you can imagine the lump they're going to remove, but you can also imagine the critical areas that you need to protect. So you're being more precise. And that's about the brain. You want precision. You want to do less harm than
Do we already have that augmented reality here in Rwanda?
I think we have now started using augmented reality in our neurosurgical procedures. We're looking forward to have. But for instance, but we have microscopes. Microscopes is like magnification. We talked about wearing glasses. Why do you wear glasses? It's like you add some reality to your eyes, right? It's a sort of augmented reality as well. So when I go in the brain and I bring in a microscope, which is like a big loop that allows me to see like 10 times, I see the very small detail, right? It's a sort of augmented reality, but that you can couple with a navigation tool. So the roadmap, you know where you're going, but you also have a nice visibility. So the 3 hospitals, my hospital, Chuk and King Faisal, we have nice microscope, latest microscope. So it's easy to see what you're going to do in a critical space with nice magnification and nice detail.
You know, one of the things that ChatGPT, for example, as an AI tool, one of the things that it has allowed people to do is to do things faster and better. Whereas before, and I had a conversation with a lawyer, Richard Mujisha, about AI in the legal field. And a lot of the conversations were about the fact that some of this less expert work will be taken over by an AI.
Yeah, right.
And so you don't need 20 lawyers to come to create a contract, for example. You just need maybe one lawyer who's feeding in the information, and then so you need a lot less human beings.
Right.
Now, that's why I was asking this question, because when I look at, say, Rwanda, right, we don't have enough human beings. We don't have enough
I see where you're
Claires.
So it's hard to replace brain surgeons.
Why?
But it's because, you know, it's not the AIs or the robotic, because if you're going to replace the brain surgeons, so we're not talking about the augmented reality and everything, we're more in the robotic, because you want more fine hands, right? Okay, there has been some robotic application in neurosurgery, like screwing in the back, but it's still being controlled by the surgeon behind, right? So you can use the screws that are being inserted by the robot, but actually it's the surgeon that is controlling that, right? So we're not yet there. To do, maybe I told you about Neuralinks.
Tell me more about what's Neuralink.
Oh my God, Neuralink is, oh my gosh. So Neuralink is a crazy, crazy, crazy neurotechnology that was created by Elon Musk and team in 2016. So it comes as, it's crazy. So implantable brain-computer interfaces. It's like you're making the brain communicate with outside devices.
What do you mean? Like, do they put is it like a microchip?
So
in the brain.
It's easy. So let's say you have someone who is paralyzed, or someone who you've heard about ALS, or someone who had a stroke, or a spinal cord injury.
Who's not able to speak.
Or someone who is not able to speak, because now there is an application in deafness, even blindness, or someone who is not able to see, but they want to communicate with the outside world. So they are able to implant, it's like a coin that is connected to a small wire. So they use a robot hands to insert the wire to the neuron, which is the smallest entity of the brain, and they stimulate. So everything is transmitted in a wireless.
It's almost like Bluetooth.
It's like Bluetooth. So there's no connection. There's nothing. They will insert the coin is there. There is a wire that goes to the brain that stimulates the brain, and then there's like a wireless connection between the wire and the device outside, and someone may have thoughts like, I want to sleep. It's being transmitted to the screen on the desktop.
So someone is there is thinking,
they say,
I want to sleep.
Yes,
and then
I want
the words
to see Sunny, and the words will come there. So it had to be FDA approved, like to be approved to be used on humans. I think the first FDA approval was like 2 years ago, and they've had few human because they started on animals, right? Now they've had few humans who've received the implants, and let's see where it's going. So only few hospitals. I think in the US there are 2, UK, Canada, Saudi Arabia, I think, yes.
One of the things with AI, and that's because AI is a great tool, but the thing with AI is it lives and dies by who is inputting information in the AI.
Yeah.
And sometimes, I think about a future where, for example, I might be in disagreement with you. I actually do believe that at some point, even all the knowledge you have will be, an AI will be able to
get everything.
To see,
but
and
who's
learn.
feeding the AI?
So right now, for example, I'm just imagining this. Like, let's say I'm creating a scenario. Maybe I'm being a bit too futuristic. You know that professor, that senior neurosurgeon who was your not an idol but mentor. Extremely well. He knows so much. Now I can imagine all that knowledge that he has being put in a large language model, some kind of AI.
Yeah.
That is then able to, and the thing with the AI, it constantly learns.
Right.
It's bringing in more and more information. It has access to every medical journal in the world.
I know.
And it's learning. And it's maybe watching you perform a surgery and learning. And eventually it will be like a medical, it will be your brain.
Right.
Because fundamentally it's your brain.
I think it can have all the information it has, but will never get the hands the professor had. Like
maybe
the fear he had at, after 30 years of experience, seeing a different patient and saying, every patient is different, because you need to feed AI, right? That, it will probably not have enough information on that new patient, right? But there are feeds in medicine that are probably going to be taken over by AI, like radiology, Now, I think one of the papers our student was reading in the morning was looking at scans of people with a certain brain tumor and predict what the histology is going to be. So the histology is when you cut a sample and you go and you see on the microscope and you make a report and say this tumor is so and so. Because the AI has seen so many similar tumors that are reported, that are being, published, that it can say, yes, tumor that look like this are going to be this.
Yeah.
You see?
You said something when we were talking earlier, a while ago, about, again, data sets.
Data sets.
Now, one of the things that happened with Africans, and I think we saw that during COVID, is that medical innovation, sometimes we are the last ones to be the beneficiaries of. When they're doing research, it's not on us. When they're doing data, because as you've said, I've learned something from you. You've taught me that fundamentally a female brain and a male brain are different. That we have different risk profiles based off of our hormonal differences. There might also be different things between Africans and white people. There might be different things between Banyarwanda and Somalis. I kind of sometimes, I guess there's a bit of a worry that with all these innovations, again, Africa will be, I guess, left behind because...
Yeah, it's concerning. And that was one of the discussions we're having. Let's say, so there's some, as I was telling you, like meningiomas are more common in Black women, right? So you probably, if we're feeding our AI with more publication, it will have
From
more
white
information on us, right? But we're not publishing enough. Now, all the tools we're using, they were FDA approved on trials done on other people rather than us, right? What tells us that, their kind of diseases are ours,
that
right?
Neuralink
yes,
works
like,
for us.
Asians, they tend to have different brain conditions. They will have more aneurysm. They have, Caucasian, they will have more brain cancer.
Really?
Like what we call gliomas. White male in a certain age, they tend to have that more than Black people, And, the tools we're using or the trials that have been done on, Western population. So until we get out and we publish and we feed the AI with our data, we're still, being compared or being given treatment that were tried on, Americans, Europeans, Asians, but were never tried on Africans because we don't even know if they will work on Africans.
I had no, actually, I'm learning so much. I had no idea that our brains, although we're all Homo sapiens, that our brains are fundamentally different, that we have different
it's not
disease
like different,
factors.
I don't know, but we tend to have different
diseases.
Geographically distributed different diseases. Like,
okay, I'm just going to ask this as a selfish question.
Yeah.
What, as a Black man, are there any things that I should...
for the brain?
Yeah. Because you've said white men
white
are
men,
more likely
they tend to have brain cancer. But
Black women are more likely
to have meningiomas, which are the lumps.
Asians are more
likely to have vascular anomalies like aneurysm.
So Black men?
Black men, I need to figure out.
Oh,
I don't know.
Listen.
I think you can have it all, but it's not as common as white. Yeah, white men.
No, it's actually. Listen, I hope. Okay, how about this? I hope you find out and quickly tell me if there are things that I should know.
I have to dig about Black men. I think Black. No, that's not Black male in general, but men in general, for example, those tend to have prostate cancer. I hope you know.
That one I know, but then we're talking about brains.
Yeah, but prostate also goes to the back and everything. Yeah.
After close to a decade of doing the work that you do, it must be so frustrating for you that even now, you're still the only female neurosurgeon in Rwanda.
I'm not.
You're not?
Yeah.
Or how many are you now?
So is it 2 years now that we have a second female?
Oh, fantastic.
Yeah, and
what's her name?
She's called Sylvie. She's in CHK.
Oh, fantastic.
Yes, and then we're having a third one coming. She's the incoming.
Yes.
Maybe in December. But incoming first years.
Yes.
Maybe for all the other years, 0 female.
So 3 women now.
3 women, but when you look at so they do 6 years. Maybe the third one who is coming, she's a 6th year student. So 5th year, 0. 4th year, 0. 3rd year, 0.
Oh, no.
2nd year, 0. Intake, 0. So, it's a bit scary. There's a lot of consideration, time taking. I think there's a lot of social constraint.
When you talk about social constraints,
I think our society is more expect you to a certain age to have kids, to be married, and to. I'm not saying that your surgery is incompatible with family life, but it can be a little bit tough when you have a family, or you may choose to further take a part that is not that too much time taking. Let's say when you finish your general neurosurgeon and you want to specialize more. So there are people who will say, okay, I will do pediatric neurosurgery. I will deal with brain tumors like me. I will deal with spine tumors. So some specialties will give you more time. But we're still where we, whether you have a specialty in neurosurgery or not, we do everything. Because, we don't have the luxury of saying, I only do brain, I only do kids, or I only do spine. You have to take care of everyone. So the work is too much time taking. And again, women get scared, a little bit on that. But I know countries that have been able to improve numbers. And when you finish, you're able to, like for instance, to say, I'm going to do spine surgery. Like for spine surgery, it's very rare that you spend the night in the hospital, for instance, because most spine cases are cold cases. If you say, I'm going to be a vascular neurosurgeon, it's like there is a stroke every second. So you're probably going to spend your time more in the hospital. We're getting there. We need
more women.
I'm not discouraging them. I'm saying it's tough. It's time taking. It's too demanding. And then when you finish, you also need to excel, So we don't want the men to tell us you're the female, You're weak because you're a woman. You see what I mean? So you don't want to feel weak because you're a woman. You want to feel as, as efficient as the men. So you tend to overwork as men work. And it's, it gets overwhelming.
Yeah. Now, let me just ask you just a curious question. When you watch these movies, I every so often I'll watch a medical movie, but I don't like the sight of blood too much, so I don't watch as much as I would like. You see them having surgeries that last hours and hours and hours. Is that actually how it is? Does it actually take that long?
So you can have a surgery that lasts 30 minutes.
Yes.
And you're saving someone's brain and you're removing blood in someone's brain. And you can have a surgery that lasts 12 hours.
12?
Yes.
Have you gone through a surgery that lasts 12 hours?
12 hours.
How do you do? Wait. And okay. How are you standing there for 12 hours? You
can stand, sit, stand, but most of those surgeries are very, very, you need a lot of concentration. So those are tough cases, tough, long cases. Like the big meningiomas that are encasing, the carotid, the nerves and everything. You basically need to find out where is the vessel so I don't punch it, where is the nerve so I don't cut it. So your brain is at a 500 maximum concentration.
Like you're concentrated.
Concentrated. And it takes time because to reach that particular space, it requires, some complicated, complex approaches that you have to learn. And you have to train yourself. And I think that's another application for, augmented virtual reality. We talked about it, get immersed before doing the surgery and, have the cask and get, if you had a virtual reality, you can simulate the surgery.
So it's almost like it allows you to practice.
Yes, you practice and, you see where but we're not doing that. So what we're doing more is courses, like cadaveric courses.
I want to know at the human level. Now, even sometimes when I'm watching a movie on TV, my mind will wander. Even if it's, it's a great movie, I'll still want to look at my phone. I'll look around. I will not focus, even if it's the best movie in the world.
Yeah.
My mind goes to different places.
Yeah.
How are you able to concentrate? Like, okay, what has been the longest
I think the
surgery?
longest I've done 12 hours.
12 hours.
But that, yes, it was crazy because so you can break them,
So how do you do it?
So sometimes the opening is tough itself. So some lumps or some tumors are in very critical location. Positioning the patient itself may take 2 hours.
Okay.
Make the patient asleep another 1 hour and a half. Make the approach, maybe you make the approach like in 3 hours. You've taken 5 hours. And then you take another 5 hours trying to remove that tumor, right?
Do you eat? I'm just wondering. 12
so
hours.
I don't want to get sick
Yes.
when I'm operating.
Like
I
vomit.
take coffee in the morning,
Okay.
and I don't want to eat too much so I don't get sick when I have a complex case.
When
That's
you,
me.
When you say sick, what do you mean?
Like like be sick or have I don't know.
So like you want to make sure you're not eating anything.
Anything that is like going to make me get out or give me any crazy stuff or what. So I want to be at my best.
So you're just going to take a coffee?
Yes, I'm going to take coffee. And sometimes you need people to help you. You need to push everyone because those long cases, you want to start early. You want to make sure everything is ready.
Do you stop and like go to the bathroom? Like
you can go to the bathroom.
Yeah.
And it's like you unscrub and scrub back in.
Yeah.
So you get the sterile clothes off, and you can get another pair when you come back in.
How do you manage yourself? How do you manage? Because I'm assuming, right? So you're dealing with probably fatigue. You're physically tired. Then there's also maybe adrenaline, and then you're dealing with adrenaline, but also the other side of adrenaline. Then you're dealing with you might even get hungry.
Hungry, yeah.
Right? Then you're also thirsty, probably, and sometimes all of that, you also have to have, as you said, 500% concentration. How do you do that with all these other things? Like how?
I mean, I would probably be a bad brain patient.
Why?
I remember when I was still a resident, the residents, when you're still a trainee, I used to get cramps, so I would spend like 3 days without sleeping. I have this, my eyes are shaking.
Why?
Because I've not slept. It's like you're missing some nutrients. Like maybe you don't have enough calcium, maybe you don't have enough potassium. I just figured out as I went on that you need to take care of yourself. Like until recently, I used to do the long surgeries, as I will tell you, and I don't eat enough, or maybe I have not hydrated enough. And I found out I had, for instance, anemia, and I didn't know, right? Until one day I was feeling a little bit dizzy, and I saw my hemoglobin was a little bit down. I said, oh my God, so I'm killing myself. Not only you're a woman, you're having menstruation maybe every month, you're losing, and you're not even eating well. So you need to pay attention. So the advice I gave you about the food and the what, I think concern every surgeon and every doctor. And we tend to forget that. I just realized that, I was forgetting myself. I was not like sleeping enough. I keep myself hydrated, but I was not probably eating well because I'll probably not take enough iron, and I was losing iron every month, and I was not even eating and what. So, look, I have anemia. I said, no, that's not correct for a doctor. So, the advice we give to patients or to people, they have to come back to us because we're not supermen or superwomen.
Do you do any mental exercises, like whether it is not yoga, but something that maybe like calms your brain to allow you to, like you said, like that 500%, is there any mechanisms that you do? And the reason I'm asking this is because obviously you, as you said, you've had a 12-hour surgery that was successful. Now, I want to know how you do it. Because maybe I won't need to do a surgery, but maybe I need to focus on something for that amount of time. Is there any mental, kung fu?
Yeah, no, I think I wasn't doing enough that time because I was taking too much stress, too much work, and I was forgetting myself. It's actually like I've had a couple of surgeries like that. Now that I know, I'm like, I don't do any meditation or anything. I just, the previous day, if I have a long case in the morning, I want to be home early. I want to have that feeling like I'm ready, If it's something I'm not, I don't know how it's going to go. I'm like, I want to wake up in that, like that feeling when you wake up, you feel like, I don't know what's going to happen, but I feel good. I feel like something good is going to happen. That's the feeling I want to bring in theater. Because if I wake up and I feel some doubt or I feel some fear, that's when maybe it doesn't go well.
Are you a prayerful woman?
I am, but I will not say that, if I go, I will panic, go on my knees and start praying for
not
my
panic,
patient.
But
yeah. So, you know what I say when I have a case in the morning or anything, I will just tell God, like, you gave me this ability to help these people, It's not like you do not give it to someone else. You gave it to me and you send this person to me. So help me help them. Because I think I believe there's like 50%, as I told you. I've had patients that say, this looks like cancer or this looks bad. I say, okay, God, help me help them. I don't know how it's going to go. I go in, take it out, patient wakes up, is a muturage, goes home. I'm like, there was God, like 50%. Me, maybe I was there like 30%, and the patient was there like 20%. But maybe 50% was God. So I believe in that kind of feeling. Like the feeling you have in the morning before you start a case, are you in peace of yourself? Are you okay? And if you take that feeling and the patient brings that feeling and God is there, I feel you have like 100% chance of helping them.
Last question. You've not hidden the fact that what you do is hard. It's hard on yourself. It's hard on your friends. They probably don't see you as much as they would like.
They don't.
Your family probably does not see you as much as you don't rest as much as you would like. So it's a sacrifice. You've worked really, really hard. You've studied really, really long. And you are now who you are. Now, because of the country that we live in, the amount of money that you take home is probably not as great as it could be. And I think that's a conversation everyone has. I think everyone from the president to a man or a woman who's sweeping the streets. I think everyone is underpaid for the kind of service that they're giving to society. But you're one of seven. So here's my thing. Why remain here? Why remain in your community? You are trained in some of the best universities in the world. You've talked to great audiences. You're able to choose. I mean, there are many doctors. If you go to the UK, you go to Canada, you're more likely to see a Black or Asian doctor than you are to see a doctor from that country.
Right.
You're seeing, I don't know if it's the same in Rwanda, but in Ghana right now, and Uganda, and Kenya actually,
Right.
you're seeing the UK, for example, actually going out and recruiting African doctors, African nurses, you know, to take care of their growing, aging population, and they're throwing money at them, life-changing money.
Right.
Why has Claire chosen to remain in Rwanda and go through the challenges that she has to go through? Why haven't you gone and joined other Black doctors, African doctors in the West and chosen to go looking for greener pastures?
Oh my God, that's a tough question. But I believe, I think I'm not, you know, as I said, I kept saying I'm not like superwoman. I'm not the only doctor who is giving back to the country, right? Even an OB who is, you know, giving a baby to a mom who carried this baby for 9 months is doing a wonderful job. And I will not say because I operate on brains that I'm some sort of special doctor. Now, you know, the way I take that question is just everyone, it's like asking you, why do you do podcasts? And we've talked about it, right? You told me, you know, I was, you know, a journalist while writing for the New Times. And, you know, I feel like I have a message that I can pass easily through my podcasts. I think it's, you want to live a life with a purpose. That's exactly what I want, right? It's having a meaningful purpose on what I'm doing. Not because I don't want a nice pay. Of course, the nice pay has to come. It has to come, and I think it has to come because that's how you retain your elements, right? Your good elements. It's, you know, you have to motivate them. But like in my class when I was in med school, I was talking with a friend. We looked back and we said, who stayed, who's actually practicing? We're less than maybe 10 of us in a class of, like 20 of us in a class of 100.
Practicing in Rwanda?
Practicing as in doing practical medicine, because others went to NGOs and what. And it's not because they want more money, but there is something that these doctors that are practicing have in common. They have that passion, despite the money, of wanting to treat patients. And I don't know, it's something that I cannot describe, but it's that feeling that I told you when I see Muturaje who came, spend the night in Nyabugogo, gets to me, has a lump in the head, I remove it, and I see him going. Those are the moments I go home, I say, God, I found my purpose. And I say, like, this is right where I belong. And then you see, I've lived in many countries, as you said. When I look back, in most countries, I probably felt lonely because my family was here, right? And that's something that I cannot get anywhere. You know, coming back to Rwanda, practicing here, and having the luxury of wanting to see my mom, and I go and see her, wanting to see my sister and her kids, and I jump and I see them. That's the joy you cannot buy with money. And I think it's one of the things that is keeping me here in Rwanda, serving the people that I don't know, that need my care, because that makes me think that I'm doing something that has a purpose. Like, it's not like I'm doing it to get paid. I'm not, you know, it's not someone high who called me, Claire, you have to see this. He's a son of who? No. This is a Muturaje who came from nowhere, having a disease, that I can treat and I get him cured. I feel like this is it.
This is why I was born.
This is why I was born. And then seeing my family, it's like, yeah, I felt lonely for many years.
Yeah.
Yeah.
Is it a lonely existence over there?
Oh, yeah. So you probably spend like 99% of your time in the hospital. And you go home tired and you're sleeping.
Then
on
you go
weekends,
back.
and then, I used to miss them on Sundays. That was the day I hated the most because you just realize how lonely you are, right? I would call my family, I would call my sister. I'm like, oh my God, I want to come back home. I'm like, I'm dying here. Yeah. So then if you look at it, it gets different for people who are trained outside, who have their spouses and their kids in schools and better schools, and they are providing. Sometimes they make that sacrifice of giving them a better life, and I cannot judge them. Yeah, saying, okay, I want my kids to grow up here, to go to nice schools, to be, I guess maybe if I was married and I had kids, I would have seen it differently, to be honest.
Well, I think speaking on behalf of the 14 million plus Rwandans,
yes,
I want to thank you for making that choice to help that Muturaje, to stand up and be counted. And on behalf of myself and my team, I want to thank you.
Thank you
for joining me today. You could have been resting at home, but you took some time and spent an hour or more of your time. I think it's a bit more. No, it's been an absolute pleasure.
Yeah.
I've learned quite a bit. If I think about my many takeaways, is the understanding that of the work that you do, but also understanding just how complex the human being is. Age, sex, geographical location,
Right.
And it almost, sometimes I regret not having a scientific bone in my body. The work that you do seems very rewarding and also challenging. And no, I just want to say thank you so much for your time.
Thank you for having me, Sunny.
Did you have a good time?
I did. I mean, when we chatted a bit, was some of the stuff you said you wanted us to chat about were a bit challenging, and I didn't want to come out and say, I'm giving you wrong information or what. So I said, okay, if it has to educate the population, then gotta be right information, right? Yeah. So I hope I provided some some clear answers. Yes. And so I hope we get more of me. Yeah.
I guess what you're saying,
it does take time,
and you've not sugarcoated it. You've literally been honest and said, you know what, it's a sacrifice.
It is, yeah.
But again, like you said, a Muturaje comes close to death, the next day walks home.
Yeah, and I have those Muturaje text me sometime.
Yes.
Yeah, I will give them my numbers. Like, oh, this is who and who. I remember you and what. So I'm like, yeah, this is why I was born.
Thank you so much for joining me, Doctor.
Thank you.
And that's a wrap for today's conversation. Thanks for staying with us till the very end. It really means a lot. I'd love to know, what was the one moment that really stood out to you? Drop it in the comments so that we can keep the discussion going. If you want to connect with us beyond YouTube or streaming platforms, you can find us on the social media platform of your choice. And if this has sparked something for you, share it with a friend who'd love it too. Until next time, have a great week.